So I'm John Mark Hirshon. I'm the Senior Vice Chair of the University of Maryland, Baltimore Institutional Review Board. And this is actually a kind of joint grand rounds, both for the IRB, but also we have a monthly trauma and emergency care research seminar, which we usually start in September. So I'm kind of having this as an extra one for that group as well. By way of background, I'm a professor in both emergency medicine and in the Department of Epi and Public Health. I've been on the IRB long time, over a dozen, I think around a dozen years or something like that. And I've been one of the vice chairs and the senior vice chair for a number of those years. What I want to talk to you about today is to talk a little bit about informed consent when it comes to research. Interestingly enough, as an aside, a colleague of mine was talking about informed consent in the emergency department when it came to clinical care, so it was kind of an interesting bookend. And there are differences between clinical care and research. And so I'm going to focus on the research component, talk a little bit about informed consent, waiver of informed consent, and exception from informed consent, which are slightly different things or significantly different things. So I'm going to talk today a little bit about about waiver of informed consent and exception from informed consent, but put it within the research context. So the first thing I'm going to say is, what are we going to cover? So I want to make sure that you're aware of what the topic is. We're going to talk a little bit about the historical perspective related to research. Okay? Then focus on consent. And we'll talk a little bit about federal regulations and how they inform us when it comes to research. We'll talk a little bit about waiver of consent versus exception from informed consent. And I want to make very clear these are two separate things within the regulation. And I'm going to talk a little bit about the history of exception from informed consent. And I'm going to put this within the context of University of Maryland, Baltimore, our program, as well as an example of what we had here a number of years ago when it came to exception from informed consent. Okay? When it comes to research, we're really trying to balance two components. We want to advance science. I mean, that's what we're trying to do research about, aside from the fact that we want to make money from the institution and all those other good things, but we're really trying to advance science. But you also have to protect human subjects research, the human subjects. And so when you look at this, it's really a balance between the advancement of science and the protection of the subjects of rights of welfare. That's what I do. That's what we do on the Institutional Review Board. Okay? And if you notice, intentionally, the subjects' rights and welfare have more weight than the advancement of science. So we very much try to balance the two. The recognition is that that our job is to make sure there's protection for human subjects. Okay? So from a historical perspective, this is the Nuremberg trials. And during World War II, there were a number of experiments that were done, not just by the Germans, but by others as well, that from our perspective were aghast at. That, historically, you can't understand what these people were thinking when they did them, but these experiments did occur. The Nuremberg trials looked at what had happened and said, we need to change, we need to improve research. And how research is done from an ethical perspective. So what we learned from the Nuremberg trials included the fact that voluntary consent of the human subject is absolutely essential. This is what's informed consent. You need to make sure that people know what research is and what's going to happen to them. Okay? So there's no coercion in the informed consent. They're supposed to be able to make that decision on informed consent. That subjects may be free to stop at any time. And there were a number of other things when it came to research, including, let me pull these all up real quick, that if you're going to do research on human subjects, it has to be based on good science. So you have to have some prior, particularly for greater than minimal risk research, you're going to look at prior animal data. You want to make sure that the scientific value is appropriate, that you justify the risks and benefits. And that's one of the big things that we look at from an IRB perspective, is to be able to justify the risks and benefits. Okay? We want to avoid any type of adverse harm if possible, and you really want to minimize the risks of death and disability. So this is from Nuremberg, so from the late 40s, okay? But in recognition that things develop over time, we learn in this process that medical practice and how we take care of patients may not be exactly the same thing as research. Research, while it's within the medical practice in the sense that it occurs simultaneously, really lies outside of medical practice. What it is that we're doing research with our patients, But the primary goal is to test a hypothesis. Okay? And so if you look at these two components, you can really say, is there a potential conflict of interest here? Now, what happens if you're a investigator that firmly believes in what you're doing, and you have to balance that with the idea of, well, I believe that in my clinical trial, group A is going to benefit and group B is not. And that's why we do randomization and we do blinding, because otherwise my bias as an investigator may impact that. So the idea really is to try to minimize the conflict of the roles by really trying to balance the perspective of both the researcher and the clinician. But that was the late 40s, and things have progressed. In the 1960s, the World Medical Association developed the Declaration of Helsinki. And again, it was been subject to multiple amendments, but focusing on the informed consent is required, but they started recognizing that not everyone can give consent. There are certain populations, vulnerable populations, if you will, that may not be able to give appropriate consent. Okay, so let me ask, what would be some of the vulnerable populations that we would expect to see around here? Limited capacity, what else? Children. Geriatric. So again, it depends on their capacity, not just simply, hopefully not being old, otherwise I may start having problems soon. What else? Prisoners. And actually in some of those groups, particularly prisoners, there are very strict regulations, because prisoners by their societal status are not allowed to make decisions when it comes to certain things. So the whole issue of informed consent takes a whole new risk or a whole new challenge when it comes to prisoners. Okay? So, okay, great. We've had Nuremberg. We've done Helsinki. We should be going great at this point, right? Unfortunately, people have a way of not always justifying that optimism. So how many of you have heard of Tuskegee? I hope almost all of you have, okay? So what happened in Tuskegee is that in the 1930s, they started looking at the natural course of syphilis. Now, back in the 1930s, they didn't have good treatment. They, wanted to follow it. But within a decade, they were able to determine that syphilis is very exquisitely sensitive to penicillin. So really, to be honest, they probably should have stopped this, by the time they realized that, but it didn't stop. What happened? They didn't disclose one of the things with consent now is you have to keep people updated with the information, so they didn't disclose the updated information. They intentionally tried to prevent treatment. The people were led to believe that spinal taps, which would be done for research purposes, were actually for treatment purposes. And so there was a lot of falsification. And this went on, again, this was 1930s when it started. It went through the 40s, the 50s, the 60s. It was only the late 60s, early 70s actually, when this came to the fore. And by public, and again, you would think, well, gee, who was doing this? Trust us, we're the federal government. This was actually a CDC-sponsored project. Okay. So that led to the next iteration of revising things. And really, this is all kind of history to bring us up to where we are in terms of federal regulation. So it developed the Belmont Report. And there were three main components of the Belmont Report. As you can see up there, it was respect for persons, beneficence, and justice. And this got codified in 81 in what's called the Common Rule, where most of the federal agencies have all signed off on the Common Rule. Now, I'll be honest, this is the federal government, so there's a little bit of regulation here, and sometimes the regulation conflicts. I know you guys don't believe that, but it actually does. So you have to understand how your research fits into it. If you're doing drugs, then maybe FDA versus the HHS. But for the most part, there's a significant concordance, and it all falls under the Common Rule. But these are the three main three main things we look at when you look at overall in terms of rules and regulations. You got to respect people. You want to minimize the harm and really, give the most benefit from it. And you want to make sure that it's fair distribution of costs and benefits. So when you look at all of this and really focusing on the consent component of it, you recognize that at first there was no consent. Then there was consent, but they didn't realize that the consent was really, there was nuances. There were vulnerable populations that we had to consider in addition to the regular population. But one of the things that they didn't include in all of this was the fact that there are some populations which can't give consent, and they may have conditions in which they need emergent life-saving interventions, but they're not able to give consent. So Michelle Biros and others published this in JAMA in 1995, look at the whole issue of informed consent for emergency research. And by this we mean someone who's got an emergency life-threatening condition in which they're not able to give consent for. So maybe it's someone who's had significant trauma and they're hemorrhaging to death. Maybe it's someone who's in acute status seizures. But these are folks that, by the nature of the disease, are an acute life-threatening event, and they can't give consent because they're not able to at that time. There was nothing in the rules. The regulations had not looked at these things. So that's why additional regulations were needed. So I'm going to take a stop away from the kind of the history perspective and move on and talk a little bit about the federal regulations. So kind of echoing what we discussed in terms of Nuremberg, there's a difference between medical practice and experiment. So in medical practice, I as a practitioner can say, I recognize it's off-label, but I can prescribe you this medication for this purposes. That's not considered an experiment. Okay, that's my discretion as a clinical practitioner. Okay, so it's designed solely to enhance the well-being of the patient. Now, as an experiment, I might want to say, well, I think this may help. So what I'm going to do is I'm going to try it on 3 people and see 3 other people and see if there's a difference. So that's when you start becoming, and really one of the key differences is I'm trying to develop systematic knowledge. I'm trying to look for generalizability to be able to take whatever I'm doing to be able to then to determine how we can move forward. Okay? But even experiment can be a little fuzzy sometimes. So research, for the IRB perspective, is activities designed to contribute to generalizable knowledge. In general, you develop a hypothesis, that's something that's testable, and you look at the conclusion related to that hypothesis. Okay? It really, ideally, is a formal process. It's not randomly given random and not in the tradition, not in the epidemiological of true random, but kind of haphazardly give it to one group versus another. This is a systematic process. It's well designed. It goes through a whole process to make sure you understand what the population is, what the hypothesis is, what the interventions are, what the risks and the benefits. This is what I look at when I look at an IRB protocol. So within that, there are specific definitions. A human subject. So how many people here would consider a dead person human subject? One. They're not, from a research perspective, they're not. From a HIPAA perspective, they are. So, but in general, it's supposed to be a living individual. When you talk about research, not HIPAA, but research is a living individual about whom an investigator conducting research obtains either data through interventions or identifiable private information. Okay? You can see where HIPAA, which is a later regulation, kind of blurs this a little bit. If I'm getting data or information about a patient who may have passed away, but it's identifiable, that's where the HIPAA comes in. But from a research perspective, they have to be alive. Okay? But it gets to some interesting conversations. We've had some interesting where it came to transplant, and at what point are you taking you're collecting materials for clinical purposes, but if you want to collect materials for research purposes, how do you define time? It can get to be some very wonderfully interesting and challenging conversations. Okay, so our responsibility on the IRB is to really, in the end, I'll go back to that scale. I want to determine benefit versus risk. Is the risk-benefit ratio okay? And the things that I look at is I look at to see what are the potential harms. And a lot of times with minimal risk, it may be loss of confidentiality. I then look at the benefits. What are the benefits? Are there direct benefits that it will help the patient or the subject, or are there kind of generalizable benefits? And when it comes to minimal risk, retrospective review, there's the risk of loss of confidentiality. It's balanced by generalizable knowledge. That's pretty standard. It becomes a little more challenging when it becomes greater than minimal risk. And especially if you're looking at greater than minimal risk with no hope of direct benefit, that's where it becomes a much more challenging discussion. And particularly when it comes to pediatrics, that category has to be approved by folks well above It essentially has to go to the federal government for many of those, particularly in Maryland, because Maryland is very restrictive when it comes to pediatric patients. So again, this is a risk-benefit analysis, and that's what my job is. And going back to where I started, where I was talking about kind of the history of things, informed consent is not a document. It's a process, okay? So if I'm going to go to someone and say, I'd like your permission to do this research, it's a relationship. I said, I'm going to keep you informed. Now, if it's a one-time thing in which all I'm doing is I'm going to collect data, I'm going to collect your stool sample for research purposes, then that's not a process. You've done that, you've completed. But if you're looking at people from, you're doing a clinical trial that you're going to follow them for 6 months or a year, if you get new information that radically alters your understanding of the research, then you need to inform the subject of that. So in the instance of Tuskegee, one of the big things was that when penicillin became effective, they recognized penicillin was effective, they should have informed them of that at that point. So it's a process. It's not just a single document. We'll look at the document, and we've gone back and forth how much wordsmithing we do. I'm not a big wordsmither. I want to make sure the information's there and the person understands what the risks are and what the potential benefits, and that I understand that the researchers understand the role of informed consent as a process, not just as a document. Okay? So that's informed consent, and that kind of leads us up to where we are right now. And from a federal regulation perspective, there's two different components to talk about here. There's waiver of informed consent versus exception from informed consent. So when I talk about waiver from informed consent, it really is an alteration of the informed consent process. And there are 4 conditions that are required to be able to do that type of waiver. Okay. First, it has to be minimal risk. Okay. So, and we'll talk in a moment about what minimal risk is defined as. Okay. It cannot adversely affect the rights and welfare of the subjects. It cannot practically be done without the waiver, and that when appropriate, the subjects will be informed of the information. Okay. So when you fill out, if you fill out the Cicero application, these questions, which are part of the federal register, those are the questions you need to answer. So if you're telling me it's minimal risk, okay, then what's the definition of minimal risk? Okay? The probability and magnitude of harm, I always have to read, this is federal language, I have to read this. The probability and magnitude of harm or discomfort anticipated in the research are not greater in and of themselves than those ordinarily encountered in daily life or during the performance of routine physical or psychological examination or tests. Sounds like lawyers wrote that, but it's federal register, so it's what we got to go by. But it at least, and part of what we're challenged with is trying to interpret those to be able to say it is or is not minimal risk. And there are some things that are pretty clear. If you're drawing a single blood, that's a minimal risk. If you're doing a retrospective chart review, that's minimal risk. If you're putting an IV in to draw multiple bloods, we consider that greater than minimal risk because that's really not something you would normally see in a doctor's office. If you're doing x-rays are specific, that's greater than minimal risk because you're putting people at risk. Ultrasound, minimal risk. And so, but think about it. If you're putting the individual at greater than what their normal activities would be or what they would normally happen at a doctor's office, then that would be greater than minimal risk. And it's open for interpretation. We go back and forth on some of the items, but really that's what we have to look at. Okay? As I said, these are some of the typical examples of minimal risk. Okay. So how does the waiver work? Well, what happens is that someone submits an application and says, I'm doing research, I'm going to do a retrospective chart review, and it's going to be of 100,000 subjects. And I would like to be able to get the data without asking for consent for everybody. Well, could they practically do that research without waiver of consent? I don't know about you, but getting 100,000 consents is a little challenging. Okay. Have they assured me that they're going to protect the subjects? Perhaps they're going to take it as de-identified data. So that great risk there is really, so it's not going to impact the rights and welfare of the subjects. Okay. And if they find something important, are they going to tell the people? Well, hopefully they'll publish it. Usually that telling them, that kind of informing folks relates to more specific if you're doing genetic analysis or, but again, those are the 4 criteria that we're going to look at. Okay? One of them, which is always a little challenge, is adversely affecting the rights of welfare subjects. Open for interpretation. What does that mean? If I collect data from somebody, how do I interpret that affecting the rights and welfare? It depends. Is it de-identified? Then I don't know who the subjects are. Is it identified? If I find something that I understand could potentially put them at risk, or let's say I'm doing some type of DNA analysis and I realize that their children may be at risk. So those are all things that kind of have to be discussed and interpreted when we get a protocol at the IRB. One of the areas that we get challenged with is, let's say we're doing a retrospective chart review, okay, of 100 people. And now they want to do a prospective data analysis or prospective collection. Well, why can't they get consent from the people they're going forward with? If it's prospective, they should be able to get consent. So perhaps we'll be able to say you can have a waiver of informed consent for these folks that have already been seen and you're not going to have interactions with. But if you're going forward, then you should be getting informed consent from them. So there's a little bit of a challenge with that, which can become more problematic when it's a large data set. And again, talk about pertinent information. So when you talk about waiver from informed consent, the 4 criteria, the most important thing to recognize is we're talking about minimal risk research. Okay? This is different from exception from informed consent. So when people come to me and say, I want to get exception from informed consent, I said, oh, really? What's the emergency condition? And they're like, what? So recognize that exception from informed consent is different from waiver. So these are called EFIC studies. Okay? And again, this has all been developed in the last 15 years or so, or 20 years. And it's really the life-threatening situation. Available treatments are unproven or unsatisfactory. Okay? And you need to collect the data. Okay? So for example, seizures, or better yet, someone has trauma, they're bleeding to death, and we want to give them a blood substitute. Okay? And we want to see whether this blood substitute will work. Well, they can't really give consent that they're going to die if we don't do something. So that's the kind of emergency condition you were talking about. And if you look these up in the lay press, every now and then one of them will come up and there'll be a big to-do because experimentation without consent. Okay? I'll talk a little bit about the exception from informed consent and the processes. But in a way, they're right, because you can't get consent. Consent is what an individual gives. You can get community involvement and information, but you really can't get consent if the person can't give it to you. So obtaining consent is not feasible. The benefits outweigh the risk, or at least the potential benefits outweigh the risks, and it's a life-threatening situation. Prior animal or preclinical studies support the research, and considering the medical condition and the subjects, the risk-benefit ratio is appropriate. The research cannot practically be done without the waiver. There's no way you can get it. Okay? And all efforts will be made to contact the legally authorized representative. So, for example, let's say I want to do research in the emergency department related to seizures. Okay? Now, I have to make a decision. That person comes in with seizures. I want to give them a medication A versus medication B. But what happens if the family member's there, who potentially could be the person to give consent? How are we going to deal with that? I recognize I've got an exception from informed consent to actually give the research, but if there's a family member there, I need to take that into account. And does that family member actually have the authority to make that decision? I mean, Maryland statute is very specific about authority when it comes to clinical care, but these are the challenges that you're going to face. Now, the consent process is kind of interesting, or actually the informing component of these is kind of relatively interesting. Because what you have to do is you have to do a consultation with the community. So what does that mean? What do we mean when we say consultation with the community?
So you can do surveys to see how they're taking these studies.
Okay, so you can do surveys. What else? What? Focus groups. Anything else? Advertising. So define the community. I think those are all great points. What else? Is there an industry standard for community consultation? Is there something in the regulations? No. There are publications that talk about it, probably about a dozen or so, because I looked this up just the other day in reference to another EFIC study we're looking at right now. So there are, and it's usually a process, but what happens is the IRB looks at the process, determines whether or not it's appropriate, gives permission to go forward with a consultation. They then bring the material back, we review it, and then make a decision whether or not we can then approve the study. And some of the things that we look at is what's the community? You know, let's say, again, the seizure example. If there are clinics that have seizure patients, that would be a great place to go to tell them about the seizure. A little harder in terms of trauma. If you look at blunt versus penetrating trauma, it can be a little more of a challenge. So defining the community appropriately, okay? Look at what type of community consultation. Now, surveys, I think, are great to gather information, but from my perspective, when it comes to community consultation, this is a conversation. It has to be bidirectional. I have to understand what their issues are as well as letting them know about the research, okay? And what's enough? Well, it's kind of hard to say. If I was doing transplant patients here, well, my catchment area may be huge because we get folks all the way from Pennsylvania, from Western Maryland, down to Virginia. You know, so now if I'm doing trauma patients, penetrating trauma patients, then my catchment area may be a little smaller. But how do I communicate with that community, those who are at risk of that? So the community consultation is a process. Again, but it's not, you can't call it community consent. The community cannot consent for an individual. Okay. What you can do is you can inform them, give people an option to be able to opt out with some type of wristband or something else, and then you can move forward in terms of this. And this is, so when one of these come to the IRB, we'll look at it multiple times, we'll defer it until all the steps are completed, and then we can go ahead and then approve it at that point. Okay. And as we talked about, the community could be multifaceted. It could be different people. So these are some of the things. And this is a real challenge if you're looking, again, at exception from informed consent at emergency conditions. So the last part I want to talk about briefly is a little bit about our program here, the Human Research Protection Program, just kind of as general information, but also look at one study that we did do for exception from informed consent a number of years ago. That study's closed now. It's been published. We have the number of EFIC studies that have come through our IRB in the last 15 years is probably less than a handful. We have a couple right now. I can think of 2 or maybe 3 others that we've seen in the last 10 to 15 years. They're not very common. So for our program, we've got the HRPO, which is the Human Research Protections Office, and the IRB, the Institutional Review Board. And the IRB is really the folks that make the determination, kind of, if you will, the judicial branch. And the HRPO is more of the executive, and maybe more, they're the ones who keep all the rules, keep us online on the IRB side, to be honest. Okay. And so the HRPO coordinates everything. We have at least 2,000 clinical research protocols. Most of those are probably minimal risk. But there's still a fair number of greater than minimal risk that we have to look at. And we have to make sure they're being done properly. And you know, I'm sure you guys have noticed it just seems regulation keeps getting more and more over the last 10 years. I'd love to say that things are getting less on the IRB side. We've tried to minimize that. Some of our metrics are much faster than industry standards. But the bottom line is that we still have to follow the regulations. And so trying to make sure things are appropriately documented. And our job is we don't want the researchers to get in trouble. We want to protect the human subjects. We want to help the researchers do what's right and keep them out of trouble. And we want to make sure the institution stays out of trouble as well. So this is always a little bit of a challenge, trying to make sure that people can advance their science while still maintaining regulatory compliance. So our mission is really to protect the rights and welfare of human subjects involved in human research that is overseen by this organization. But our real mission is to foster the highest caliber of research we can, because we want it to be done right, and we want to support the investigators. Okay. What we do, there are a number of different things we do in the IRB and the HRPO. We look at new protocols. Now, let me be clear. Before we get a new protocol, it has to be approved by the department. It's scientifically reviewed. The department is supposed to look at it from a science perspective. Some departments do better with this than others, and I can only roll my eyes at some of the others, but we'll leave that for another day. But there are some that have committees that look at it. Now, how quickly they do it may vary, but the idea is really to make sure that before it comes to us, the science is good. Our job is to look at the ethics, but if the science is not good, we can't even get to the ethical evaluation. Okay. So we look at new protocols, we look at renewals. Every year, protocols have to be renewed unless they're exempt, so you have minimal risk if they're expedited. We look at modifications, and we also look at what's now called reportable new information, which may be a new investigator's brochure, it may be a deviation or something may have happened. So those are the things we look at as well. And just to make it even more complicated, while this is all done at the University of Maryland, we're also the IRB for the VA. And the VA, for those who don't know it, the VA has its own unique set of rules that we won't get into now either. So really, in the end, what I want to do is look at the benefits versus risk and try to make sure that the benefits outweigh the risk and that people are maintained within the regulatory compliance. So this smiling group of faces are the current chairs and vice chairs. Dr. Rosenthal in the center is the chair. I'm the senior vice chair, and then a number of us. Jim Campbell does a lot of the educational component. He's the director of our kind of research training program, though he works a lot with Dr. Edelman, who is a past chair. So as you can see, we try to maintain a relatively broad group. Our dentist, Dr. Myler, just stepped down recently. We get people from the School of Nursing. But we're always looking for good IRB members. And we're always looking for folks who really want to do it right. So if you're interested, talk to me or talk to one of the folks at the HRPO. We're always looking for more people to help in terms of the review. And I have to be honest, from my perspective, it's been one of the most educational processes I've done. Because when you've looked at as many protocols as I have, you get a real sense of what's good and what's not. For those who are PIs, if you've ever sat on a study section, it's the same type of sense. Or if you do reviews as an editor, again, you're looking at the details and trying to understand what's going on. Our process has changed about 5 years ago, so now we have meetings about 3 times a week. The meeting is about 2 hours long. We're supposed to get through about 15 different items in a meeting, and so the idea is to be efficient and effective. If you look online, you'll see actually how long it takes to have a protocol go through. So now, I'll go back to what I said. It has to come to us first. So if the person in your department has gone on vacation for 2 weeks, don't blame the IRB that we didn't get it. But once the minimal risk comes to us, we can get those usually turned around within 2 weeks, and then greater than minimal risk about 4 weeks. Now, if we send it back to the investigator and the investigator needs to do something and they don't do it for 4 weeks, then again, don't yell at us. We need to get the investigator to take care of it. By regulation, we have to have a non-scientist. So our quorum, we kind of restructured it. So now our committee is about 6 with lots of alternates. But out of those 6, we need to have at least 4 to be able to make a decision because you have to have greater than half. And out of that, we need to make sure that one of them is a non-scientist. We also look for unaffiliated, so folks from the community. And again, that's an area that we're always challenged to find good community folks who are non-scientists, who are unaffiliated. These are all things that we look at. If we look at VA, we have to have a VA rep. Okay. Again, what I said, does the protocol make sense? Is it scientifically good? Okay. What's the objective? How are they planning to do the objective? Is it adequate sample size? Now, it's not our job on the IRB to determine sample size, but if they can't tell me what they're doing, then I don't have confidence they're going to be able to do good research. And why am I going to put research subjects at risk if the science is not going to produce anything meaningful? It doesn't mean it's a negative study, but if the science is not done well, it's not a negative study, it's a meaningless study. So that's what we need to look at. Is there adequate protection of data? So one of the things is, does everyone know the difference between privacy and confidentiality for this? What's privacy?
Protection of the interactions with the individual yourself and your perception of what others will hear or see.
So if I go into a room to interview somebody and there's a whole mess of people around, that's not particularly private. Okay. Now, there may be reasons that you have family there or something like that, but the idea is that with privacy, it's really that interaction, it's protecting the person's privacy. If you think about it from a clinical perspective, you don't examine people, in front of a whole mess of other people, except for here at the University of Maryland when you have lots of residents and medical students. But again, that's a whole different story. What's confidentiality?
The data of the patients.
Right, so you need to make sure the data is secure. That the data, and how many times have we heard VA data, IRS data, federal data? Anyway, the issue of keeping data secure is part of what we have to look at as well. But again, from my perspective, we're talking about informed consent. We want to make sure the informed consent is appropriate and that it adequately covers the risks and benefit and what's going to happen. One of the things we look at, particularly for some of the more complicated ones, is how long is the person going to be on there? What are their activities? So we'll ask them to put in a study schedule so that if you are getting the information, you understand what your responsibilities are as a subject. Okay. So the PI is really critical to all this, okay? So the PI is the one who has to understand what their roles and responsibility are, make sure that the subjects are protected, make sure they maintain regulatory compliance, and make sure that it's being done in the right way. So in the end, the principal investigator is the critical component for doing high-quality research. It's our job to make sure that they stay in compliance, but also our job to help them. So often what we'll do when we get a protocol that comes to the IRB that you just question the science and multiple issues, we'll say, why don't you go get some training? So that, and we have the mechanism to train them to try to help them understand a little bit. Now, if there's a department where we get lots of folks coming through that are issues, then we'll have to go talk to the department, and we'll do that too. Okay? And we all do this online because one of the things is you have to have documentation. So now we have everything documented electronically through the Cicero, which is our electronic system. So any interactions is documented so that if you get audited by the FDA because you're doing a drug study, all the interactions with the IRB are there. The minutes are available. Everything's available. We are probably a little bit on the conservative side, but we've been audited. Well, not always audited, but we've had inspections probably almost every year on average for the last 10 years. We're probably 10 out of the last 12. Whether it's the accreditation body, which is HRPO, or the VA folks, or the federal folks, or some other folks. So we've learned just to be a little bit on the conservative side, and we don't get in trouble. If you know about auditors, auditors will always find some problem, because if they don't find problems, then they're not doing their job. So there's always going to be something, but you want to make sure that something is not something major. So we've tried to systemize things. We have checklists to make sure that when we review it, we know. And if you're putting a protocol in, these checklists are online, so you can make sure that you've met everything that you need to do. Okay? So we talked about history of why we have a human research protection program and with a focus on informed consent. We talked a little bit about waiver of informed consent versus exception from informed consent. And we talked a little bit about our program here. So I want to spend the last 5 or 7 minutes really talking about an example. So there's a neurologic emergency trial and treatment network, the NET network, that does research related to neurologic diseases. This is actually going to go away because they're going to be refunding it to look at all emergency conditions. So a lot of the things that we talked about related to emergency medicine or emergency conditions will probably fall under the new, what's called to be called SIREN. They come up with wonderful names, but it's called SIREN. Okay, so it's an NIH-funded trial based. The main folks are in Michigan. They've done a number of different protocols and research. They've looked at head trauma. They've looked at seizures. They have other things they're going to look at. So this is really individuals who fit the exception from informed consent. And these folks, I was there as an IRB representative a number of years ago where we sat and had a big discussion about how to do exception from informed consent. And I represented, because we were one of the original sites funded, so I was down there representing the IRB. Okay? And so this is their net, and this is their discussion about the EFIC studies. Okay? So one of the studies they did early on was called rapid anticonvulsant medications prior to arrival trial. or the Rampart trial. And what they were doing here is that in the pre-hospital setting, they want to know what medications worked for seizures. Now, we use different medications all the time, and in fact, a lot of the medications being used, not a lot, but they were looking at lorazepam versus, I think it was Ativan versus Valium, but the issue was that they weren't necessarily approved. They were just being used because they were effective. So we didn't know whether they were equal, how to deliver it. They were being used, but we can't just presume, we can't just assume, we need to make sure we know what works and why. And I got it published in the New England Journal. So it was to compare the intramuscular midazolam with that of intravenous lorazepam for children and adults in status epilepticus. Status epilepticus means they're seizing, they have not stopped seizing. It's a life-threatening condition because as they continue to seize, the potential that they'll stop breathing and they would die. So there's really a emergent condition as by definition. And they were trying to do this in the pre-hospital setting, so they had to get the paramedics in their different sites to be part of this. So, as I said, it meets the criteria for an EFIC study. It's an emergency condition, potential for life-threatening, time-sensitive, and clinical studies supported it, or prior studies supported it. Okay. So, there was, as I talked about, an extensive discussion before the research got started. And we talked about the community consultation. And a lot of what we talked about in terms of going out to talk to the communities, they went to talk to seizure clinics, they went and talked to larger community groups, they documented who they talked with, they brought the material back, we reviewed it from the IRB perspective, we made sure there was opt-out bracelets. So these are all what's been developed over the last decade in terms of best practices related to community consultation. So, and they started in 2008. With a network meeting, but the actual submission to the IRB here was 2009, was when the first time we reviewed it, and we approved it by October 2009. That included all the different community consultation steps, going back and forth multiple times. So great, they've got an IRB-approved protocol. Can they do the research? Well, they need to deal with the pre-hospital providers, okay? So the pre-hospital providers hadn't done anything like this before either, okay? So, and this was supposed to be for adults and for children. So they went to the pre-hospital providers, Maryland Institute for Emergency Medical Services Systems, MIMS, to get their consent, or to get their approval and to be able to roll this out. And the problem is that they hadn't really done this before. They took a very long time. And in the end, their AG, their assistant, I forget, Attorney General, their Assistant Attorney General, Assistant AG, determined that they couldn't do the research on pediatrics. So in the end, they were able to get approval, but this was a long process that required not just us, but somebody else consent in terms of from an organizational perspective. So by the time they were done, it took them a couple years to be able to get the approval to do this. The number we enrolled was relatively minimal. Still, we were able to do it, but these are the challenges. And let me be clear, my job is to protect human subjects, but I'm also sensitive to the fact that we need to be able to enroll subjects if we want to be successful at doing research. So, again, what have we covered? I talked a little bit about why we have a human research protection program, the historical perspective. Unfortunately, it's not been a great history, so that's why we do what we do. I hope everyone here understands the difference between waiver of informed consent for minimal risk versus exception from informed consent. Okay? Talked a little bit about the federal regulations and talked a little bit about our program. I think, in summary, we can do EFIC studies here. I've talked to other places in which, because of history there, they're very challenged in terms of being able to do it, because they've had the bad press in the past, experiment without consent. So they're very risk adverse to doing EFIC studies. But again, these are things that we can do, and we're happy to work with you. And in fact, this is a relationship. If you have something that requires exception from informed consent, you need to get to know us pretty well, because we're the ones who are going to help you get it through the process. I think with that, I'm going to go ahead and stop, see if you guys have any questions. I very much appreciate your attention, and thank you. Any questions?
So I guess my question comes into when you get to, non-emergency conditions when you have people and you're trying to deal with capacity to do informed consent. So, for example, I do people with dementia and delirium. And there's some people who may come to a setting by themselves who probably don't have the capacity to make medical decision-making or research decision-making. And I might want to know, how do they differ? How do they do? How in the world would I ever study that? Because they're being given medical advice. They're being sent home by themselves to carry out this medical advice. But if I try to do an evaluation to sign consent, they're probably going to fail.
And I think that's a great challenging question. What I would say is this: we hold people from a research perspective at a higher. So for example, for clinical care, if a 16-year-old came into me and wanted contraceptives, I can give them contraceptives. Okay, but if I want to do research on it, I can't. Okay, because again, we're very a little more challenged than this, but still, what I would say is this: is if they're not able to really give informed consent for clinical care, they really can't give informed consent for research. So they'll have to develop a alternate mechanism to be able to get that informed consent. I think where it becomes even more challenging is, let's say you've talked to the family member has given consent, and then they refuse, that they don't give assent. Again, if we're dealing with kids, if the children don't give assent, it's very challenging to be able to do research on them. So there's the potential for difficulty with enrollment, potential for also biases within that, but at the same time, we need to respect people, and so that's the challenge. And the best is to try to formulate how you're going to approach it, and then we can take a look at that and see. But as long as you're respecting the subjects to the best of their ability and your ability, I think that's the way you move forward. Any other question? Last chance. But I'm around if you guys have any questions. Thank you very much for your attention.